Hello, everybody. Welcome on this beautiful day over here in The Haan in Belgium. Welcome on this live event. Well, I was already very much looking forward to this specific event because it's the very first time that I give a live webinar about shockwave therapy in orthopedic medicine. So I'm curious. There's only one little pity, so to speak. You are there, but I can't see you. But feel free to introduce yourself in the chat. On the right side of your screen, you have a chat, so you can use that to introduce yourself, to ask some questions, to communicate with each other. Feel free. I saw on the participant list that we have again several people from several countries all over Europe, and also outside Europe. So some of the participants can't join live because of time lapses, time differences. But don't worry, you're all going to receive an email at the end of the webinar with a replay link. And this replay link is valid for another 3 days. So you can watch it whenever you want. Okay. Later on, I'm also going to put the recording of the webinar on the online masterclass, but more about that in the future. Well, as usual, I'm broadcasting from our Orthopaedic Medicine International Training Center over here in The Haan, where we organized the Mastermind private training program. And in that perspective, I have very good news because finally, after 1 year and a half, we're going to have a live event again over here with 4 guests in September. So if you're interested in this kind of event, well, just surf to the website and check the information. Of course, I'm not doing that alone, so let me introduce myself. I'm Stephen. I'm responsible for the Global Cyriax Institute, and together with my international teaching team, we cover courses in modern orthopedic medicine all over the world. So in the team, we have members from Slovenia, Italy, Poland, Argentina, Bangladesh. So we cover quite a part of the world. But of course, today we're going to talk about shockwave. And first of all, I would like to tell you why do I use shockwave in my clinical practice over here. Well, before I tell you that, I just want to say to you that this is not a product placement webinar. Yeah. I don't get any sponsorship from any company whatsoever who produces shockwave apparatus, and I didn't ask for any sponsorship. It's just my experience and the experience from people in our group that I would like to share with you. But okay, so why do I use shockwave in daily practice? Well, actually, because in certain situations, for me, this is a pretty interesting accessory or added value. And when you registered for this webinar, you had the opportunity to also ask questions before today. And I noticed that, I just have to look at my paper, I noticed that Chris asked me a very interesting question, and he asked, can I replace deep transverse friction massage of Cyriax by shockwave, or is it an additional technique? Well, super question, because this is also my motivation to incorporate that in daily practice. Let's be honest, performing deep transverse friction massage techniques in certain situations, for instance, for tendinosis, ligamentous lesions, muscle lesions, yes, it can be very interesting. It can be very efficient when we respect the indications, contraindications, and more specifically, the technical aspect. But it's boring. Yeah, it's boring, and it's hard work. It's very hard work. Yeah, so many people share the same experience. But okay, I'm not going to talk about all the indications and the technical aspects today. This is part of an other part in my online course on orthopedic medicine. But specifically in chronic situations, for instance, a chronic supraspinatus, a chronic Achilles tendon, I perform my transverse friction massage technique, of course, in combination with our exercise therapy, and specifically for tendons, as you surely know, our loading strategy techniques. Yeah, okay, we do that. It's better, but it's not okay. The patient still doesn't have 100%. He didn't recuperate 100% of his capacity, of his function. And yes, that could be very frustrating, not only for the patient, but also for the therapist. And specifically in those cases, in those chronic cases, I started to add shockwave therapy. And what did I see then? That, hey, I got some extra benefit, or the patient got some extra benefit. And indeed, the optimal or better results. So that's good news. Just to make sure that we are talking about the same, I'm talking about radial shockwave therapy. I'm not talking about high energy focused shockwave therapy. Okay, just radial shockwave therapy. That's what most of us use in clinical practice. Yeah. Okay, so to answer the question from Chris, does it fully replace friction massage? I wouldn't say no, but is it a super extra benefit? Oh, yes. And let's be honest, only friction massage, only shockwave? No. We are certainly in cases of tendon problems, we need also our exercise therapy. But the added value for me is very interesting. Yeah. Okay, that's why do I do shockwave. But why did I decide to organize this live event, this webinar? And the main reason for that is, let's say, some frustration. And where is the frustration? Many people do shockwave, but if I see how they are doing shockwave, when I watch many films on YouTube and films from some certain producers and literature, for instance, scientific articles on shockwave therapy in some rotator cuff problem, I always see the same. And what do I see? They shoot all over the place. Yeah, really all over the place. And we shoot a little bit over here and a little bit over there and there, and we shoot all over the place. Tennis elbow, we shoot over here, we shoot over there, all over the place. And to be honest, I find that a little bit strange, yeah, because my question is, what are you shooting? Yeah, what's the purpose? If you shoot all over the place, supraspinatus, infraspinatus, perhaps subscapularis, a little bit of the subdeltoid bursa, biceps, whatever, then perhaps you're going to be lucky and you're going to hit some interesting spot. But I honestly think we can optimize the shockwave procedure by optimizing our diagnostic procedure. And that's what orthopedic medicine is about. Yeah. I'm never going to shoot all over the place. If my clinical examination shows me that most likely infraspinatus, tenoperiosteal aspect is going to be, let's say, the culprit or a major element in the pathology of the patient, why shouldn't I aim with my shockwave specifically to the point? I have nothing against to travel around, but at least we need to know what we are doing and why we are doing it and where we are doing it. And that's the purpose of this webinar. I would like to give you some tips and tricks to optimize your diagnosis and to optimize your shockwave strategy. Yeah. Well, so that's what I would like to avoid. Yeah, killing mice with an elephant. Yeah, there's no reason whatsoever to shoot all over the place. So remember, if in the meantime you have any questions or suggestions, feel free to use the chat. But I'm alone over here, so I have to take care of the presentation and the technical part. And once in a while, I'm going to have a look at the chat and see if there are questions. And perhaps I can give you some feedback over there. And we also have time at the end of the webinar for extra questions. So before we shoot, what are my indications? Well, in general, tendinosis is a good indication, plantar fasciitis, calcifying tendinosis. And when we talk about tendinosis, of course, the most popular ones are our famous tennis and golfer elbows, everything related to the rotator cuff, and Achilles is also very, very popular. But two little remarks. Let's imagine you see the patient with an acute tendinous lesion. Don't do it. You see the patient with an acute plantar fasciitis. Don't do it. This is torture. If you put shockwave on acute plantar fasciitis, I don't think the patient is going to love you very much. Yeah. Okay. So more specifically in chronic cases, that's more indicated. And then a little side remark regarding the calcifying tendinosis. When you look at the literature on shockwave therapy, then we have to be honest. Low energy and medium energy radial shockwave therapy doesn't have such success results when it comes to calcifying tendinosis. If you really would like to get rid of a calcification, well, then you need more high energy shockwave and more focused shockwave, and radial is not that optimal. So shooting the calcification, let it disappear by radial, medium or low energy shockwave therapy. So we have to put it a little bit into perspective. But then another side remark. Yes, there could be a calcification somewhere in supraspinatus or one of his friends. Yeah. So what? We see a calcification on medical imaging. The patient has certain symptoms, and this is a traditional mistake which is always happening in orthopedic medicine. You see something on medical imaging, and the patient has complaints, 1 + 1 is 2. No, in orthopedic medicine, 1 + 1 is 3. In the majority of the cases, a calcification is totally asymptomatic. So there's no need to shoot this calcification in the majority of the cases. That's something we really have to realize. And in the majority of the cases, this calcification also disappears after some time automatically. It could take some time. It could even take some years, but in many cases, it disappears. So keep that in mind. Once again, diagnosis. Diagnosis is so super important. Okay, what are the effects of shockwave therapy? Well, you see the effects on the slide. Those are the things that automatically happen. Okay, nice to know. It's also a little bit similar as effects that happen with deep transverse friction massage. Yes, you can also create real changes, structural changes in soft tissue by using this technique in favor of the patient. Shockwave, of course, is a little bit more intense than a simple friction massage. Okay, let me show you what I use in my practice over here. I use an apparatus from the company Zimmer, the N-Pulse. And there is a specific reason why, yeah, I like to work with this apparatus, but I'm going to explain that reason. It's a practical reason. I'm going to explain that to you a little bit later on. Okay. Well, as you already saw, this is yeah, the pistol. Yeah. Okay. We have different sizes of heads, and the producer also allows to put some cup on it, as you can see, the blue cup. To be honest, I never use that, and the reason for which I never use that, because you lose so much of the energy you send into the patient's body. Yeah, this is really yeah, let's say the very soft version. So okay, it's nice that they provide that, but to be honest, I really don't need that. Yeah? And indeed, you have different sizes, and specifically the little one there. That's very to the point. Well, I also come back to that a little bit later on, because that could be, I find that interesting, because that could be very interesting for, well, let me put the big screen on again. Yeah, we're going to talk about tennis elbow, and there's one specific spot which is very interesting to reach, but when the head of the pistol is too big, then this is interesting, because here I have a real nice to the point contact. Yeah, so that's, yeah, very practical. There is another reason why I like to use this apparatus, because let me come back to big screen again. It's because of this. Most of the pistols, they are really like a real pistol, and then you have to push somewhere over here to to shoot, but that's how you have it in your hand. But personally, I always found that I used to work with a system like that in the past, and personally, I find that this is a little bit unpractical to shoot on certain spots, because you're going to see that later on. Sometimes we have to make the lesion more accessible to have a better contact with your pistol on the lesion, and yeah, I find it more unpractical. For instance, I go back to a tennis elbow, when I can take the pistol just like this, relax, and just tag, and I activate. Let me go to the presentation again. But I can activate the shots by a foot pedal. Then I have my two hands free to play, and I can maneuver in a more free way. And this is for me, yeah, super practical. I love the system with a foot pedal. Yeah? But this, once again, this is just practical. Okay, we know what the indications are, but do we know what the contraindications are? Well, of course we know that. I'm sure you know that. You see the contraindications over there. Yeah? A question I sometimes get when I use the pistol, do I use some product as an interface, let's say some ultrasound gel or something like this? Personally, no. If I notice that the patient has a sensitive skin and that I could create a little wound, then I use a layer of cotton wool between the head of the pistol and the skin of the patient. I find that very interesting, because another reason why I don't use the gel is, and this is also a practical reason, producers don't like that you use the gel, because if you lose the gel, at a certain moment it can enter in your pistol, and it can cause some disturbance over there, some mechanical disturbance, and the guarantee of your device is not 100% guaranteed anymore. So this is also something to think about. So I replaced the gel by a little bit of cotton wool. Okay. Then there are situations which are not super contraindicated, but where you probably better don't do it. Yeah, where it is a better choice not to do it. Yeah. But this is also something which is logical. Look at the fibromyalgia patient. If he's in, let's say, in a more acute phase, if you go to certain spots with your Shockwave, well, I don't think he's going to be very happy. Yeah, okay. But then we also have to talk about, okay, the energy. Some apparatus, they give their energy in millijoules, some in millijoules per square millimeter, most of the apparatus in bar. And if you compare here the two devices, because the impulse system is an electromagnetic system, is not a compressed air system. But I would like to know, okay, how much energy am I using? Well, this is a nice table we can use for our reference. This is the output energy. Yeah? This is the energy at the end of the pistol. This is not the energy that really enters in the specific structure of this patient, yeah? Because it all depends on how deep is the structure, what is the acoustic impedance of this structure. So actually we can't really know how much energy is really specifically in this structure. But okay, we work with the output energy. But okay, the major question today. You are all clinicians. I'm sure that you all see shoulder patients. Can you make today the clinical distinction between, for instance, a shoulder stage 3 arthritis, a supraspinatus, tenoperiosteal tendinosis, a chronic subdeltoid bursitis, or an acromioclavicular lesion? Can you make the clinical distinction? If you say, yeah, no problem, I know the several clinical images, then my reaction is, okay, great, super. If you say, this is not 100% clear for me yet, well, this is the absolute basis of orthopedic medicine. Manage your basics into perfection. Before you think of shooting, before you think of using Shockwave, you better think of this. Because imagine the patient has an arthritis. Why should I do Shockwave? That's not indicated. Yeah. Perhaps in this bursitis, perhaps, but some parts of the subdeltoid bursa or the subacromial bursa you can't reach. Yeah? So a good diagnosis is really, or a more relevant diagnosis is, let's say, recommendable. Yeah. So this is, to be honest, this is my passion. Yeah, clinical reasoning. Yeah. How can you analyze the patient? How can you come to a conclusion? And then you're going to see when you reach, let's say, a more valid conclusion, and then you use your Shockwave in certain situations, you're going to have even better results. Because I'm convinced that at this moment, people who use Shockwave, they already have nice results. But nice is not good enough. Let's go for more. Yeah? Okay. Let's imagine. We talk about supraspinatus. Yeah. Okay. Where is there a problem in supraspinatus? And just let me make a quick, simple drawing. Is there a problem over there in the supraspinatus? Is it more a tenoperiosteal problem, or is there a problem more over here in the musculotendinous junction? Well, I can already tell you that the second option is super rare. Yeah, in 99% of the cases, we talk about the tenoperiosteal option. Okay, but how can you know? How can you suspect that there is a problem supraspinatus tenoperiosteal? Well, now the fun is coming. Okay, which clinical test is positive when you think of supraspinatus? Of course, mainly it's going to be the resisted abduction. Resisted abduction, maximal isometrical contraction, yeah, is going to be painful, mostly. But that's not enough. If we find in the examination also a beautiful painful arc, and you are familiar with the concept of painful arc. No pain, no pain, no pain, oh, pain, 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 oops, and no pain. That means that something is squeezed in temporarily between humerus and acromion. It can't be the deltoid, but most likely the supra. And which part of the supra? The tenoperiosteal part. Or you find in the examination passive elevation, the end range pain on passive elevation. Also something is squeezed in combination with pain on resisted abduction. Hey, we might think of supraspinatus involvement tenoperiosteal. How beautiful is that? And then we can aim our shockwave in that direction. So that's why knowledge of a good basic functional examination is so important. And of course, if necessary, we have a number of additional tests, but this is something I explain in other online courses in every little detail. So you can palpate the supraspinatus. It's strange. I have been teaching courses around the world now in about 37 countries the last 25 years. And everywhere I see similar mistakes. People think they palpate the supraspinatus, but in reality they are palpating the acromion. They use the wrong technique. And I not only see that during live seminars, I also see that in literature. I have several articles that came across on deep friction massage of supraspinatus, and they are miles away from the supraspinatus. So we really have to ask questions. Okay, well, let me show you how you can palpate this tenoperiosteal aspect of supraspinatus in a more relevant way. I'm going to show you a film now. Yeah, it's a film about the deep friction technique, but don't think of deep friction. Deep friction is just a palpation that takes 15 minutes. Yeah, but it's about how can you find it. Okay, so let me look for the film. The patient sits with his arm behind the back. We can palpate the spine of the scapula in the lateral direction. As soon as we lose contact with the bone, we come back onto the bone and palpate in an anterior direction. We know for sure that we are on the acromion. The tendon, with its insertion on the greater tuberosity, is found just beyond the anterior edge of the acromion. The deep friction is done in the normal way, with the index finger of the homolateral hand reinforced by the middle finger. The thumb should be placed quite far down the arm, so that a downward pressure is exerted on the greater tuberosity, the index fingernail remaining horizontal. If we put the thumb posteriorly, with the nail of the index finger pointing anteriorly, a pressure is exerted to the front of the acromion, frictioning the acromion instead of the supraspinatus. But I made a mistake. Sorry for that. I come back. Yeah. Yeah, managing the technical part during a webinar, many things at the same time. And once in a while, I do a little mistake, but now it's okay. Huh? Okay, thank you. Thank you for letting me know on time. So, zip, I restart. Yeah. What you saw on the film is when we use this position in our hand with our hand to palpate, you're going to palpate the acromion. When you use this position, then you have more chances to reach the tenoperiosteal aspect, and we're going to apply that in our shockwave strategy. Yeah. So as I showed you, you're going to let me do it like this. You're going to really shoot in this direction. Yeah, and you're going to shoot all over the insertion of the supraspinatus. And it doesn't make any sense to shoot all over the place. So go to supraspinatus tenoperiosteal. Okay? Good. And of course, you think of your clinical image. Your clinical image is going to tell you, I have to go in this direction, or I have to go, for instance, in this direction. Let's imagine there's a problem in the musculotendinous junction, which is not frequent. But if the problem lies in the musculotendinous junction, so in other words, let me make a drawing again. If the problem lies more over there, then you're not going to have any localizing sign. We're not going to have a painful arc. We're not going to have end range pain on passive elevation. You're just going to have pain on resisted abduction. Yeah. Okay. And then it's easy. Then you just put the pistol over there and you shoot over there. Okay. What about infraspinatus? Okay, where is the problem, or where could be the problem with infraspinatus? Well, again, somewhere over here. Practically never. Somewhere over there. Practically never. But in the majority of the cases, it is again tenoperiosteal. This is really, really the top of the bill. Okay, what do you find? What do you find in your examination? It is copy-paste. When we compare that with the story of a supraspinatus, it's copy-paste. Do you find a painful arc or end-range pain on passive elevation in combination with pain on resisted lateral rotation, then you can think of an infraspinatus stenoperiosteal. Again, we're going to hit another point. And there are two positions which are interesting to palpate this spot in, let's say, in a more easy way. You can do it in the prone lying position, but this is not always very comfortable for the patient. We incorporate three elements: 90 degrees elbow flexion, some lateral rotation, some adduction. And then you get some tension in this posterior part, which makes it easier to palpate the infraspinatus. But I always do it in the side lying. That's more comfortable for the patient. And where exactly, how can you find this stenoperiosteal spot? Well, this is the spot where you find, or where you feel, tendon and bone at the same time. Yeah, if I just would palpate, okay, if I just would palpate over here, then under the spina, of course, then I just feel muscle, I just feel soft muscle. I go a little bit more over there, and the palpation, super important, otherwise you don't feel anything. The palpation is not just push, because then you don't feel anything. The palpation is a supination movement. So in the first arrow, you feel muscle. The second arrow, yeah, you feel some more cable structure. But if you push a little bit more down, then you can still go deeper. And then when you reach that spot, then you feel, I call that toing, tuk. You feel cable, toing, and tuk. Bone. You have the combination of cable and bone, and most likely the patient is also going to say, "Hallelujah!" It's going to be sensitive, most likely. That's the place to be. That's also the place, remember, where we have a painful arc, where you have end range pain on passive elevation, or the combination of the two. Yeah. Okay. So we're going to put the patient in this position. And we're going to aim our shockwave then again in this direction. So again, we have a more, let's say, specific orientation of our shockwave. Okay? So far, so good for everybody? What about subscapularis? What would be the clinical image of the subscapularis? Of course, the patient is going to give pain or mention pain on resisted medial rotation. Okay, mostly. But which part of the subscapularis? Well, let me make a drawing again. You see that the insertion of the subscapularis is pretty big. So there could be a problem more in the cranial part. And if there is a problem more in the cranial part, you know what you can find in the examination? You can find an accessory painful arc. If there is more a problem in the caudal part, then you can find accessory pain on passive horizontal adduction. That's also perhaps nice to know. Okay. But then the question is, how can you find the subscapularis? Because the subscapularis lies deep, is also covered partly by some fibers of the deltoid. Well, there is in fact a little trick, yeah. And the little trick is that, oh, by the way, before the little trick, this is a subscapularis live, yeah. So you see how pretty big this insertion is, yeah. Okay. So what is going to be the palpation trick? You palpate under the clavicle from medial to lateral. And a certain moment, you just feel, okay, it's soft, 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 soft. And a certain moment, you feel something hard, you feel bone. This is the coracoid process. And what you do then, you just go a little bit deeper, yeah? And then you palpate again more in a lateral direction. Until, as you see on the image, where the thumb is, then you are on tuberculum minus. And this is tuberculum minus, yeah, this is the insertion of the subscapularis. So simply use this simple, I call that the Zorro palpation, yeah, yeah, and it's very easy to reach the tuberculum minus. And then again, you can shoot over there, yeah. But take into account, it's a big insertion. So make sure you shoot over the whole insertion. Remember, if the patient has more painful arc, you can focus more on the cranial part. If the patient has pain on passive horizontal adduction, you can focus more on the caudal part. Yeah. Okay. And in this way, we can really make Shockwave our results, or we can optimize our results. Okay. If you have any questions until now, just shoot in the chat. In the meantime, I told you that you're going to get a replay link of the webinar, which is valid for 3 days. But the webinar is also going to be published on the online masterclass, and together with all the previous webinars I gave and a lot of other content. And I would like to invite you to go to the online masterclass, to make an account so that you can have a free online course in orthopedic medicine. Yeah. If it's okay for you, I'm just going to share my screen with you. Voila. Okay, and then we go to orthopaedicmedicine.eu. Okay, and what you see over here, well, this is one big toolbox, organized joint per joint, shoulder, elbow, wrist, hip, and so on and so on. And in every toolbox, you have a series of lessons on different topics, on functional examination, diagnosis, clinical reasoning, treatment strategy, and so on and so on. But today, you can get here your free discovery course. And in the discovery course, I have 14 different lessons, also about differential diagnosis in the shoulder, some quizzes, some games. The only thing you have to do is just click on it, and you just make an account. And of course, I already have an account, so I'm going to log in into my personal account. And then you can very easily open the lesson of your choice. For instance, shoulder arthritis. Okay, we click on that, and the lesson automatically starts. Let's have a look at the diagnostic interpretation of an arthritis in the shoulder. Well, before we do that, and in every lesson, there's also a link to the specific handout. Okay. So let's go back to the slides. So go to orthopaedicmedicine.eu and make an account and get your free discovery course. If you're interested in the major content of the toolbox, well, at the end of this webinar, I'm going to do you a pretty special offer, but I just do that at the end. So we talked a little bit about the shoulder. Let's talk about the elbow. Tennis elbow, golfer elbow is also super popular when it comes to application of Shockwave. And also there, in so many films, I noticed that, this is shooting all over the place. Okay, and by coincidence, we hit some interesting spots. But before we shoot, what would be the clinical image of a tennis elbow? Well, you probably know that. Yeah. Okay. most likely your resisted wrist extension from an extended position is going to be pretty painful. Yeah, yeah. Certainly with the acute tennis elbow, sometimes it's oh, yeah. If you repeat the test and you do a fist and you do it again, it's still painful. And if you then ask the patient to do a radial deviation against resistance, that could be painful, but not necessarily. It could be. Yeah? Okay. Those are the, let's say the major positive tests, but I'm sure you're familiar with that. But then I would like to know which type of tennis elbow do we have? And I'm talking about a local tennis elbow. I'm talking about a local problem. I'm not talking about a so-called tennis elbow which is related with, for instance, a cervical problem or with certain nervous problems. This is another story. Okay, I'm talking about a real local musculotendinous problem. Okay, so how many types do we have? Well, we have I can give you 4 different types. In some books you find 5 types. If you want 5 types, I can also give you 5 types. That's no problem. But type number 1 is going to be extensor carpi radialis longus, the insertion. Type 2, extensor carpi radialis brevis, the insertion. And then type 3 is more the tendinous body. And type 4 is a muscle belly. The absolute numero uno, the absolute number 1, the most frequent one is type 2. Yeah. And I really also would like to illustrate that on film later on. So how do you palpate? How do you palpate type 1? Well, you put your thumb on the lateral epicondyle, like this. You go with your thumb a little bit higher. And then you flex your thumb, as you can see on the slide. And when you then exert a pressure in posterior direction, then you are on the anterior border of this humerus. And this is the insertion of the type number 1. So if this one is the most sensitive one in your clinical examination, because you're going to palpate the 4 different types, then I'm going to aim with my pistol more specifically in that direction. Yeah. Yeah, I'm really going to shoot like this. And then I go up and down. And then it's also interesting that perhaps you use this little one or the medium one. Here on the picture on the slide I use the medium one, but it also depends a little bit on the size of the elbow of the patient, and also on the amount of fatty soft tissue in this neighborhood, of course. Yeah, but it's obvious that for type 1 this is going to be your shooting direction. Type 3, the tendinous body, well, there you're going to go to another position. Yeah, the arm of the patient is relaxed and 3/4 extension, some pronation. You support the arm, and again, you can shoot in a very easy way. With those techniques, it's so practical that I have let's say a good contact with my pistol, that I don't have this long contact. This, for me personally, this makes it a little bit more easier and more comfortable. But then type 2, super frequent. And when I told you earlier that the supraspinatus palpation technique is most likely the number 1 screwed up technique worldwide, well, tennis elbow type 2, he deserves a good second place. Also, mostly people are somewhere in the neighborhood, but not really to the point. And what is the definition of to the point? You have to be on the anterior aspect of the lateral epicondyle, the anterior aspect, not the epicondyle itself. And you can only palpate that with a real flexed thumb. And since this is not such an easy palpation, I'm going to show this one also on video for you, okay? The starting position is 90 degrees flexion and supination. The therapist's thumb is 90 degrees flexed, with the tip of the thumb lateral to the lateral epicondyle. The structure lies at the front of the epicondyle, therefore he brings his thumb now onto the anterior aspect of the bone. The other fingers act as a fulcrum at the medial side of the elbow. The active phase of the deep friction is a translation movement at the front of the lateral epicondyle, with pressure applied in a medial downward direction. To avoid losing contact with the lesion, the patient should not abduct his arm, nor should our thumb be put too high or too flat. Using a layer of cotton wool between finger and skin could be used to prevent damage to the skin. Okay, and now I didn't forget to switch on my microphone again. The layer of cotton wool here, also on this technique, when I do shockwave over there, I always use some cotton wool over there because it's quite, let's say, a vulnerable spot. Okay, good. So you're going to put your pistol like this. And then it's easy again that with my left hand, I can support the elbow, and with my right hand, I have the freedom of movement to shoot. And of course, this is the direction, and I'm going to shoot a little bit like this so that I can have the complete insertion. Okay. How many shots? How much energy? What is the frequency? Of course, when you have a shockwave, all the shockwave producers, they have pre-programmed settings to make life easier for us. Thank you very much. But in general, let's say I like to go to 3-4 bar. Yeah, if it's acceptable for the patient. Again, it may not be torture. I use a frequency mostly around 12 hertz, and I use 2,500 until 3,000 shocks. That's a little bit the average what I use. Yeah, okay, and once a week. Okay. And then the last option is the muscle belly option, and this is of course logical. You're going to put your pistol there on the muscle belly, but again, this is not so frequent. So the absolute majority is our type 2. But golfer elbow, the good friend of tennis elbow. What are we talking about? Well, we are talking about a problem here at the medial epicondyle. But again, when we palpate, don't make the mistake to palpate the medial epicondyle itself. In certain cases, this is more sensitive than the soft tissue, but don't be misled. Yeah, I'm not going to shoot on the medial epicondyle. Yeah? We find the soft tissue, so in other words, the insertion of the flexus is over there on the anterior aspect of the medial epicondyle. So automatically, I'm going to put also my pistol over there. So the starting position of the patient is going to be with the arm in full extension. Keep the arm in full extension, and then you can easily shoot over there. Actually, there are two options. You can go to the tenoperiosteal aspect, is anterior on medial epicondyle, but there could also be another option, which is the musculotendinous junction lies a little bit further distally. Clinically, that's very easy. What do you find? You find the resisted flexion of the wrist is positive. And sometimes you also find that the resisted pronation is also painful. And this is a little bit misleading, but there is a good reason for that, because here we have, of course, the common flexor origin, and the pronator is also partly inserting over there. So the one can influence the other, yeah? But it's not a standard rule that the pronation is positive, but it could be. Don't be surprised, okay? So make sure the arm is in full extension, keep it in full extension, and that you aim your applicator or the pistol tenoperiosteal or at the musculotendinous junction. Okay? And then, what about our good friend Achilles? Yeah, he's of course a super top scorer. And also here, we have to check several localizations. Everybody is checking the medial and the lateral aspect of the tendinous body. Everybody. But also don't forget to check an extra part, the anteromedial part of the tendon or the anterolateral part of the tendon. And perhaps also the insertion. And again, then we can change a little bit our shockwave strategy. So when we palpate the medial and the lateral aspect of the tendon, a little suggestion I can make. It's easier with your both hands. And with your leg, you build in a little bit of dorsiflexion in the foot of the patient, as you can see on the slide. So you build in a little bit of tension, and then it's easier to palpate the whole area. And how are you going to palpate? Well, with both hands, you're going to do something similar. You're going to push the skin down, you're going to close, and you're going to lift it up. Yeah, no pressure, pressure, no pressure, pressure. This is the deep friction maneuver, but it's also the palpation maneuver. Don't do this. Yeah, don't squeeze with your fingers flexed. That's not a good idea. But up, up, up. Very, very easily. And yeah, you check, let's say, the last 10, 15 centimeters. And on the most painful spot, you can, of course, apply the shockwave. And then, as you can see on the image, the foot of the patient outside the treatment table. With my leg, I build in some dorsiflexion in the foot to get some tension in this tendon. And then it's I have my two hands free, and then I very easily can shoot along the lateral aspect of the tendon, and of course also along the medial aspect of the tendon. And then the question, what about the dorsal aspect? Well, there is very, 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 very rarely a real problem at the dorsal aspect. So mostly it's medial lateral. But as I told you, also check the anteromedial or the anterolateral aspect. And how can you do that in the case of the anterolateral aspect? Then the patient's foot is in plantarflexion, the tendon is relaxed. And you're going to push with one thumb, you're going to push the tendon aside. And then with your other hand, with the finger, you can move a little bit at the more anterior aspect of the tendon. And you can do that by using this kind of position, and you do kind of supination movement. And you also check, let's say, the last 10 centimeters. And on the most painful spot, you can also aim some shockwave over there. And then okay, palpation, again, anteromedial, well, same logic. And what do I do here? Well, okay, as you can see, the foot of the patient in plantarflexion. With my left thumb, I'm pushing the tendon a little bit aside. And then with my pistol, I don't come 100% lateral, but I try to come, of course, I'm lateral, but also a little bit more anterior. Yeah. And like this, I can also, let's say, reach another extra aspect of the tendon, making things, let's say, more specific again, yeah, and perhaps more efficient. Okay. This is the palpation of the insertion. A problem at the insertion is also pretty rare. Yeah. Okay. But okay, if necessary, you can do also Shockwave over there. But to be honest, until now, I've never done it. I've never done it. It's always the two previous versions. And then slowly but surely we come to the end of this story. But let's talk also a little bit about quadriceps. You could have a muscle belly lesion, but you could also have a parapatellar problem. You could have a tendinosis, suprapatellar, infrapatellar, but also parapatellar. And there we can also change a few little details. Yeah, for instance, here infrapatellar, or is it infra or supra? I took the patient so close. The picture, it's suprapatellar. Yeah. What is the trick? What is the trick to reach this suprapatellar aspect? Well, the trick is that with one hand, you push the lower half of the patella down. And what is going to happen? The proximal part of the patella is going to tilt a little bit. Whip. And then with the other hand, it's easy to come more or less under it. And then we have more tenoperiosteal contact. You have bony contact and you have muscle fiber contact. And this is also something you can do with your Shockwave. Or in that case, infrapatellar, same logic. Yeah. Let me go to big screen again. Yeah. You just push, in that case, the proximal part of the patella, you push it down. Then the distal part is going to flip. And then with your ring finger, you can palpate here on this aspect, more tenoperiosteal. And you just look for the more sensitive spot. Okay? Well, and you're going to do exactly the same with your applicator or with your pistol. Yeah. Make sure you push the patella down and then try to have a more, again, specific contact when you shoot, supra and infrapatellar. Parapatellar, to be honest, with Shockwave, that's practically almost impossible. Yeah, there we really have to stick to our friction massage technique, because it's yeah, I tried it several times, but the table is in the way, the pistol is too long. To be honest, I didn't find a good solution for that yet, for the parapatellar version, medial or lateral. But okay, supra and infrapatellar is also pretty frequent. Okay. Yeah, as you can see, this is the palpation for the medial parapatellar aspect. And yeah, imagine, how do I have to get there with my pistol? Yeah, then I have to come from below and try to shoot in anterior direction. This is really not practical. Huh? Okay. And certainly on the other side, it's even less practical. But okay, when you make a diagnosis, you also have to check. You have to check those localizations. Okay, dear colleagues, that was an overview of some practical aspects on the application of Shockwave. So what is next on the program? Well, before I forget it, I still have something for you. On the right side of your screen, you're going to see a PDF file. Radial Shockwave Therapy webinar slides. Do you see the file? Yeah. Okay. When you click on this file, you can automatically download the slides of this webinar, all the slides. Okay. So do it now. Yeah. In the meantime, I'm going to have a look at the chat again. Is the frequency and the pressure always the same for all tendon problems? That's a good question. Well, to be honest, I don't have this information. I already looked for this kind of information. Are we going to use another frequency for a supraspinatus or another intensity in comparison with the tennis elbow, in comparison with an Achilles tendon? To be honest, I don't know if this information is available. I don't know if those studies exist. I also had a look at the information provided by the International Medical Shockwave Society, because they have a lot of good reference material. So, to be honest, for a supraspinatus and a tennis elbow, I use the same frequency. So I stick to 12 hertz. And for what is concerned intensity, I go as high as possible. Yeah. I start mostly around 3 bar, 2.5, 3 bar. That's to not to let's say to frighten the patient too much at the beginning, but then I like to go to 3-4 bar, certainly 4 bar. Yeah. But the standard is as much as the patient can tolerate. That's the standard. And then Ida is asking, 1 bar application is usually very painful, even though the injury is chronic. Should we say to our patient that he suffers through the therapy, or should we use different technique? Well, to be honest, I'm a little bit surprised. 1 bar, I find that still very sympathetic. Personally, also did it on myself, and okay, my wife is also a colleague. We work together, so she had the pleasure of shooting on me all over the place because I really want to feel it. And to be honest, 1 bar, that's not so much. So could be that the patient is hypersensitive. Yeah. That's one option. And secondly, yes, please check your diagnosis. Huh? Let's imagine that the patient has some kind of periostitis, and then we shoot with 1 bar over there. Then I'm not going to be happy either. Yeah, it's going to be pretty problematic. So, and then the second part of your question: are we going to say to our patient, "Okay, suffer, you just have to deal with it"? No, I'm not a sadist. Yeah, I go as high as possible. I say to my patient, "Listen, it's not a pleasure trip. Yeah, listen, it's going to be sensitive, but you tell me if too sensitive." And then I stop for a few seconds, and then I restart again, and I see where we come. Yeah. But if the patient has tears in his eyes because you torture the patient too much, no. So this is a little bit trial and error. Yeah, and so mostly I may go to about, yesterday, for instance, yesterday I had a tennis elbow type 2, and there, well, I went to 4 bar, and it was not so nice. She had pain. Yeah, okay, but we could do it. What else do we have here in the questions? Annalene is asking, after how many sessions do we have to see that it is better? Let's say about, in my experience, average of about 4 sessions. Yeah. Sometimes it's faster, but okay, average of 4 sessions. How many sessions do I give in total? I give about, maximum it's going to be around 6 sessions, something like this. Yeah. And then Chris is asking, so 120 millijoules, 150 millijoules on the applicator? Yes. Let me, where did I put that little paper here again? Yeah. Remember in the slides, it's in this, I showed you this one. Yeah. So 185 millijoules is already 5 bar. So 5 bar is something I didn't reach yet with tennis elbows, because that's a little bit, for my patients, apparently a little bit too heavy. Yeah. But I told you that in all the machines there are pre-programmed settings. Yeah? And if I look, for instance, at a pre-programmed setting for a chronic tennis elbow in the device I'm using, then I can go to maximum 120 millijoules. So then I don't use that pre-programmed setting. Then I just use the free setting so that I can increase. Yeah. And that automatically also, I think, answers the next question. And then the next question, no pause between shocks, 2,500 shocks in a row. To be honest, I do that rarely, also because for the comfort of the patient. Once in a while, after 700 shocks, 700 shocks, I stop a few seconds, just 2-3 seconds, and then, okay, and then I hit again. And I noticed that makes it a little bit easier for the patient. My tennis elbow patient yesterday, 4 bar, yeah, it was heavy, and the patient several times said, "Oh, stop now." And then I stopped. A few seconds, and I continued, and then, okay, we managed. So yes, I take once in a while a little break. Okay, any more suggestions? Any more questions? Did you already download the PDF? Okay. I have something else for you. Again, if you look at the right side of the screen, you're going to see there the link to the online masterclass, the link to your free discovery course. Right? When you click on this link, you automatically come on the registration page to make your own account so that you can have access to your free discovery courses. Okay. Annelien is also asking, in a plantar fasciitis, very common, the abductor hallucis is also very painful. Also, do you treat this also? Yes, you can do that, no problem. Yeah, and one little detail. It's good that you ask me. Where is mostly the, let's say, the hot spot in plantar fasciitis? Mostly the hot spot is the anteromedial part of calcaneus. When you palpate the plantar aspect, and perhaps you're going to have several sensitive spots in the plantar aspect, and then you come to the anteromedial part of the calcaneus. Whoa, that's the place to be. Yeah. So I'm going to focus over there, but there's no reason or there's no rule that says why you can't take the whole plantar fascia. So I focus over there, and I also do the rest of the plantar fascia and perhaps the muscle, what you suggest. Chris is asking, do you combine the Shockwave once a week and additional 2 times deep friction, or will that be too much in your opinion? Well, I also like that question. I do once a week the Shockwave, and the deep friction, I do that 2, maximum 3 times per week. Research is also showing that in chronic lesions, you don't need to have 3, 4, 5 sessions, not necessarily 3, 4, 5 sessions a week of deep friction. When you do 2 or 3 sessions, that's already more than enough. So more specifically, so when we go to the tennis elbow, I see that patient 2, maximum 3 times per week. I do my friction technique. We do stretching technique. He gets home exercise. Remember, we are talking about tendon. We are talking about tendinopathy. So he gets loading exercise, and he gets 1 Shockwave per week. That's a little bit my strategy. So it's always a combination of elements. But as I told you at the in the introduction, In the past, I already did a combination, but still I saw some patients which, yeah, you have some result, but not 100% result. And then I started adding the Shockwave. Well, the Shockwave was for me the extra value, and one step further. But it's a combination. And then Ida is asking, how many days, for example, in tennis elbow, do you leave in between the Shockwave therapies? Well, once a week. Once a week is okay. Yeah. So, any other suggestions? Feel free before you can enjoy the rest of the day. Okay, you have the link above your chat. So if you're interested in the online masterclass, so go for your free online course. But as I promised, at the end of the webinar, I would give you a special offer for those of you who really want to go deeper into the stuff. Well, here is the offer. Yeah, we have 3 levels in the masterclass. We have a free discovery level. We have a silver level, in which I have 59 courses. So we talk about everything except lumbar spine. And then we have a gold upgrade, and you have unlimited access until 1 April 2022 on tablet, smartphone, whatever. This is the actual situation, but because you join this webinar, because you invest time in this webinar, you get a special offer. You sign in for the silver course, you choose the gold upgrade, but you get it for free. And on top of that, you also have free personal consulting through WhatsApp or through Skype, where I guide you in your study process. And you just use the discount code FREEGOLD. To summarize, you go to orthopaedicmedicine.eu, you click on Get Access, then you choose whatever course module you click, then you come on a registration page, you click on the gold upgrade, and then you fill in your bonus code FREEGOLD. You click on the white arrow to activate your bonus code, you choose your payment method, and automatically you get an email with your login data and of course also an official invoice, and you can start with your discovery. So, if there are no more questions, I'm just going to wait a few more seconds to see if there are some more questions in the chat. Well, then the only thing I have to do is thank you very much for joining this live event. Thank you for your interaction. Thank you for your questions. I hope it was interesting for you and that you can apply those little details in your daily practice. If you have any further questions, you know where I live. You just send me an email, or through the website you can also contact me. So enjoy your weekend, have a beautiful day, and I'm going to say goodbye to you with a beautiful picture from along the beach, along the coastline over here in The Haan. So enjoy your day. Thank you very much. Bye-bye. Ciao.